Our first choice in case of a complex humeral head fracture is a locking plate with a distal proximal humeral head screw. However, in case of a patient with other 3 or 4 elderly patients, very elderly patients, or patients with many fractures, we use the Humerusblock. Good clinical and radiographical results were obtained in different trauma centers with the Humerusblock. However, one of the most important drawbacks is that the perforation of the humeral head, the so-called controlled impaction, the sintering effect by the Kirchner wires, requires early removal of the implant in 20 to 40% of cases. In no study, the amount of the impaction was calculated. So the aim of our study was to evaluate the amount and the rate of the humeral head impaction, its influence on the maintenance of the cervical diaphyseal angle, and the clinical results. 46 consecutive patients treated with a closed or minimally invasive reduction and osteosynthesis using the Humerusblock. The diagnosis and the classification was performed on the trauma series X-ray and on CT scans. Fractures were classified according to the Herter classification, while the various values of the upper humerus and the impaction, destruction, angulation of the humeral head was assessed following the Rush criteria. On the basis of the legal classification, we measured the posteromedial metaphyseal extension, the integrity of the medial hinge, the metaphyseal comminution, and at the end of the operation, fracture stability was consistently assessed by testing the abduction with the arm in internal and external rotation under fluoroscopy. Accuracy of the fracture reduction was assessed according to the BARS criteria, while the shoulder clinical function was evaluated with the constant score. Applying a well-known measurement, in this case the dimension of the block, and applying the appropriate proportion, we established the distance between the Kirchner wires and the articular surface of the humeral head. We repeated the measurements at the follow-up period and obtained the amount of impaction of the humeral head. Obviously, in the vast majority of the cases, we performed the same measurements on the CT scans. The cervical diaphyseal angle was evaluated according to the Hertel classification, and obviously angle of 130, 102, 140 was considered a correct reduction of the fracture. Obviously, all the data were submitted to statistical analysis. The table shows the fracture details. The mean sintering effect was on the humeral head was 3.9 millimeters, and we observed a strong correlation between the amount of the impaction and the patient's age, higher in patients older than 50 years old, in female with a particular type of fractures, type 7 and 12, above all with the varus impacted, the varus obstructed, and above all with the metaphyseal comminution. We obtained satisfactory results in terms of reduction of the fracture in 80% of cases. At the follow-up, 90% of these patients maintained the reduction of the fractures. We had 4 bad results, and in each of these patients at the beginning there were a comminution of the metaphyseal area. The Humerusblock was removed in 40% of cases because of Kirchner wires perforation of the humeral head, but only one case had a discomfort, a local discomfort on the humeral side. A negative statistical significant correlation was found between amount of sintering and the constant score. So, conclusions. The mean sintering effect was 3.9 millimeters, 80% of satisfactory results to follow up, low number of intraoperative complications, and the perforation of the humeral head required a mandatory implant removal in 40% of cases. So, take-home message. It is conceivable that a distance of 5 millimeters can be used by a sort of safe zone between the Kircher wires and the humeral head surface. But I think that the most important message is that Humerusblock is not able to control fracture impaction and reduction in case of metaphyseal comminution. We appreciate it very much for your attention.